The task that I was asked to do was to review Chapter 1 of the state health plan, provide my feedback and recommendations for improving the way the analysis is conducted. Next slide. Within the Chapter 1, there were a mention of high-risk areas and populations that were important to the state. What I did here was list them and their publicly available data source. These data are all available at least the county level. A lot of them, the zip code and even census tract level, which in an urban area, census tract is pretty much a neighborhood level of analysis. Today, I'm going to focus on the second to the bottom, that bright orange colored section. It's social vulnerability index based on the Chapter 1 priority population for public health emergencies. This is available publicly from the CDC. And if you go to the next slide, I'll define it a bit further. It's the degree to which a county exhibits certain social conditions. It's based on 3 major indicators, all from the American Community Survey, which is a product of the US Census, and multiple sub indicators. They include socioeconomic status, household composition and disability, minority status and language barriers, and housing type and transportation. These data are available at the county level, but also at the census tract or neighborhood level. What they tell us is the ability to prevent human suffering and financial loss in the event of a disaster, and that includes a public health emergency or a severe weather event. The social vulnerability index, the values range from 0 to 1, with higher values indicating greater vulnerability. And I've listed a few here. So the lowest value was found in Itawamba County, which is in the Northeast. The highest was in Holmes, and that's in the Delta region. And the median is what we would expect right in the middle at 0.51. Next slide. You know, we're missing a slide here that I wanted to show. It basically is the distribution of the social vulnerability index at the county level. And it really showed the darkest colors or the highest values or the most vulnerable live the majority of those counties were in the Delta region. A lot of them lined the western part of the state, a lot of those counties. And so what I want to show you here is how we used 2 indicators together, looking at a relationship between con approval, and that's per 1,000 population. So it's a rate, not the number, and then life expectancy by county. So life expectancy being a proxy for population health. And so if you look at the color legend there on the right at the top, what I was able to do was categorize counties according to high, medium, and low values by placing roughly an equal number of counties in each category. And what you see here are the ability to locate any kind of clustering, for example, where both values are high, where con approvals are high, but also life expectancy is high. So an area where things are going well. You are also able to identify counties where the con approval rate is very low and the life expectancy is very low. So areas where to focus. And what I did, so then in the middle there on the right is a scatter plot showing the relationship at the county level. So each of those circles represents a county. And what we notice is an inverse or negative relationship by approval rate and life expectancy. So what does that mean? That means that there is a tendency for counties that have a lower approval rating to have a higher life expectancy. And the opposite is also true. In counties that have a higher approval rating, the life expectancy was lower. So if you go across the x-axis or the bottom line that goes from left to right, there's an outlier there, Quitman County, which had the highest approval rate. So not the highest number of approvals, but the rate per population. So that's an interesting finding. The next thing I did was I stratified the counties by low social vulnerability and high social vulnerability. Again, placing roughly an equal number of counties in each category. And we did not see a difference. Again, the relationship was still negative. Sometimes when we stratify our associations, we can tease out some important findings. For example, one could be turn positive, meaning when one goes up, the other also goes up. But in this case, we see the same pattern. And so key counties where both indicators are low, those are the lightest color counties, and they're almost impossible to see. They are located in the Delta on the western boundary. They include Adams, Bolivar, and there's a couple more further down, Pike and Washington counties. If you go to the next slide, I've replicated it's the same map, but what I've done is create tables where I've aggregated the two indicators by region and also gave a grand total, so a benchmark to compare the regions to. And what we found was that the lowest median life expectancy values were in the high social vulnerability county regions, and especially in the Delta and the Northwest. Next slide. And this is just a slide showing the findings, which I've already discussed. If we go to the next analysis, the next analysis shows, again, the same approval rate, but this time, instead of life expectancy, we look at the relationship between total population growth rate. And this is a projected growth rate, a 5-year 2023 to 2027 growth rate. And what we can see, again, in this scatter plot in the middle here, it says relationship by county. Quitman is a high outlier for that. And then there is a strong and significant or negative inverse association between application approval rates and projected population growth. So again, the trend is where the growth rate is high, the approval rating is low. And where the approval rating is high, the growth rate is low. So it's a inverse or negative association. And again, and that association was statistically significant without having stratified by social vulnerability index. And when we did, we still see a negative association in the two county categories for social vulnerability, but they were both no longer significant. So let's see, if we go to the next slide, we see then for the aggregated values, I think what was most significant, or which popped up the most to me, is that the only positive median growth rate in the high social vulnerability category or regions was the coast region. It was the only positive. Otherwise, everything else was negative growth in terms of total population. So gave you a way to look at your data, your kind of approvals with population health, stratifying by priority population groups, a way to identify either clustering in the maps of high need areas, or outliers with the use of the scatter plots, and a way to benchmark some of the regions using the same kind of data. So is there, I think there's another slide in this group. Oh, again, here is a summary of my findings for the two past maps that I presented. If we go to the next slide, I just have a couple of recommendations. Definitely use the publicly available data sources to target high-risk areas and populations. You know, you're going to use your findings to inform cost-effective resource distribution. You can identify pockets of innovation, so areas where you're doing well that you want to replicate elsewhere, and then expand or transform services to fill gaps. And I am happy to take any questions.
All right, any questions?
Yeah, maybe I missed it, but I did not see taking into account the rural population, which varies across the state, and certainly has some of the same limitation and resources that other populations have, minority populations, the Delta, et cetera. But I mean, that's still a significant factor. And I was just curious if that was evaluated.
Yeah, no, we looked at the social vulnerability index, which one of the categories would have been transportation, poverty was another, and so but definitely can stratify by rural, non-rural counties to identify differences. That is certainly another target population that can be used.
I mean, that's all important. But you don't, by being rural, there's less access to a variety of services and care, et cetera. So I do think it is important to take that into consideration.
Yeah, agreed.
Good points. What other questions?
Okay, and just again to let the group know that Anissa has lots of different maps where she's looked at kind of the same structure for nursing home beds and for nursing home beds and pediatricians. So you'll be able to look through those as well. We just wanted to make sure you understand the methodology she used by which she stratified by that SVI. And then, Rick, we can run some by rural versus non-rural and take a look. My guess is it's going to be pretty similar, but we just want to make sure we confirm, because that's a good point. Last thing we did, and I think this will be an area that many of you are interested in. If you go to the next slide, and go ahead and move on. What we did was we worked with the department to pick 6 states to compare, really do a good deep dive on your regulations, your process, your statutes. And so I'm going to go through these. We looked at the services out of the peer states that we looked at. Mississippi has the highest number of services and activities that are regulated by CON. We looked at your fees. You do have high application fees, but you do not have a way to backfill costs to support the program. So in other states, there are general fund dollars. So, you know, that one on the fees is, yes, your fees are higher, but we think that that's because, you know, when you look at the total way that the program is supported, it's different in Mississippi. Criteria and thresholds, we'll go through those. States have different ways in which they look at the criteria and the threshold. a lot of which are more streamlined than what you're doing. And some of them have a different approach instead of a population approach, and I'll talk about that. The next slide, we have a huge spreadsheet that includes a ton of parameters that we compared across these states. So if you really want to do a deep dive and you really want to look at, for example, capital expenditure threshold, you guys are at 1.5 for major medical equipment, and you can see Alabama's at 2, et cetera. So we have a big spreadsheet like this where that we're going to provide to the department as well. So next slide. So one of the things, we did 2 things here. One is a deep dive on, like I said, their regulations, their documents, but we also interviewed these folks. And so as you read through these, there's a lot of information. Again, if slides are not your thing, these will be better to refer to in that big matrix. But really, Alabama, in my mind, has one of the most structured programs we saw. They review about 50 to 60 applications per year. Again, you can see their high approval rate. That's very similar to yours. But on the next slide, one of the things that they did is they completely redid all their formulas. And this was like a 5-year process. Their licensure and certificate of need are completely separate. They do not share data across those 2 functions. And you're going to hear that over all these 5 states that we talked to. You can see they have 12 staff that run this program. They have about 50 board members because they have different working groups. Again, they process applications, change in ownership as well. This was an interesting one that they have these occupancy exemptions. And one of the things that they look at, again, they don't use population as a basis for their formulas. They use utilization. And we have all their formulas we're happy to share. And basically, they're looking at bed days, or they're looking at service utilization to make a determination about demand. But they're not discounting the fact that if your occupancy rate is high, that's actually a good thing. And so they're not just approving applications to say, well, occupancy is at a certain level. But to be clear, their targets are about 75%. And occupancy in your hospitals, about half your hospitals is about 40% or less. So it's not a 1-for-1. You couldn't just take and adapt their formulas. But again, this is something to consider in terms of using utilization instead of population. So next slide. We also talked to Arkansas. Interesting thing about Arkansas, they do not review hospitals as part of their certificate of need. One of the hot areas they have there is home health. And they have put a really tight control over home health agencies. They were getting a lot of saturation across counties. You can see in some of the conversations we talked to them about. They have a smallish staff. They have about 90 days where they process these applications. Again, licensure is separate there. And they as well have areas of the state where they don't see a lot of applications in that southeast corner of the state. Couple of other interesting things we saw. Again, they don't have CON for hospitals, but they do for some of the other facilities. And change in ownership is done by licensure. It's not done by certificate of need staff. So next slide. Georgia. So if you all have been following the news, there has been quite a lot of interim committees about certificate of need program in Georgia. This has been a hot topic there as well. Again, looking at their capital expenditure threshold, about $10 million. They have criteria for evaluation on very similar themes that you do, but they have a tiered filing structure. And again, that's based on cost. So next slide. When we talk to them on the phone, again, certificate of need and licensure are separate. Again, they've had quite a few interim meetings and some recommendations that have come out of there. There was a conversation across all states about the infrastructure behind licensure and certificate of need, whether or not states have systems that are up to date. And when we get to Tennessee, they're the only state that we talked to that has really put a lot of money into a new system and really gone through that process. A couple of other states are in the middle of it, but are trying. So next slide. If you can advance to the, okay, Tennessee. Interesting thing about Tennessee, so their certificate of need process is very similar to yours in terms of activities and facilities. They also include non-residential SUD centers and outpatient behavioral health treatment centers. Some interesting exemptions that they have here, and I'll talk about those in just a moment. Their criteria for review includes a section focused on the licensure of the facility and the quality of care for the past 3 years. So they have to present their quality of care information, which I know you all ask questions about quality as well. They have this minimum filing fee of $3,000 and a maximum of about $40,000. And the next slide. Next slide about the conversation. Oh, this was an interesting thing. Their health planning is completely separate from their certificate of need. They have a separate report. They have a separate staff that does the health planning. It's all available online. They've got some really great infographics, and they have a separate committee that sits outside the certificate of need board that oversees this. And so, again, they consider these two separate processes. Next slide. When we talk to them on the phone, they have a pretty small staff, 5 staff. They have a large number of applications. They get through those in about 45 to 60 days. They have a high approval rating for those. Again, change in ownership goes through licensure and not certificate of need. And then in that blue box, they have some really interesting exemptions. So one is for MRIs in counties with more than 175,000, you are exempted from the certificate of need process. They have similar exemptions for home health as well. They also, the legislature comes in each session and designates economically distressed counties, and those are also carved out of the certificate of need program. So if you're in a county that's designated, and they talked about a couple of those, you do not have to pay the fees. You do not have to go through the process. Again, this is the only state we talked to that has a brand new, fantastic IT system, but it took them about 10 years to get there, and they used money from the CARES Act to do that. So next slide. Louisiana, this is the only state we did not get a chance to speak to on the phone yet. We're still trying to work on that. They cover certain facilities and beds. They don't cover hospitals, major medical equipment, or healthcare services. They don't have a capital expenditure threshold. They do not allow competitors to participate within the CON application or review process. So you can't oppose, you can't interject. And then you can see the application fees. They also call it something different. It's not certificate of need. So really this next 2 slides is what I want to stop and take some time on. Again, these are key differences between what's happening in Mississippi and these peer states. So one, you've got a high number of services, more than any of the other states. And in terms of the types of services, we can differentiate, we can pull those out for you, but you have the highest number of services. Again, your application filing fee is higher, but you don't have a backfill for your funding source for your program and your staff there. So that's one thing to think about. Exemptions. One of the things we heard quite clearly from some states is we don't want to include areas where we absolutely know that we're not going to catch up. So remember that I showed you at the beginning, those slides about the number of OBGYNs and the number of pediatricians. We had several other slides about behavioral health, and they said we want to exempt those areas because we're never going to catch up. We're so far behind. So behavioral health services, PRTFs came up, anything related to prenatal care, NICUs, et cetera. And again, Tennessee had these carved out areas where of exemptions as well. Financial disclosure, there was one state that actually required folks to tell you how much they spend on legal fees and staff costs to get those applications processed. If you recall from the literature review, I found that was about $125,000. That's pretty consistent. But you know, is that too high of a hill to climb for some of facilities that are interested in this and maybe are in the Delta region? If you want transparency into that, you know, that could be a question you start to ask if you're thinking about is there a way to make some exemptions? Separate licensure, again, every state we talk to sees these as separate. We know you're using licensure information in your CON process, and you're one of the only states doing that in this peer group. So next slide. If you were interested in looking at a different way to do these formulas and simplify them, again, there was that example in Alabama that, you know, they have a pretty strong opinion that utilization is a much better way to look at this instead of population ratios. And that there are ways to make exceptions for utilization for facilities that have high occupancy rates. Tennessee, again, on number 9, has that fantastic way that they separate their health planning from their CON process and report. And it's a shorter document, and it's absolutely transparent, and a really good one to look at if you're interested in that. Number 10, I apologize, there's a typo there. Mississippi seems to be a state where there's not really follow-up after the application is approved. So we don't see any execution to see if there was execution and it was done to fidelity. And so it's not clear if what they're telling you in their application actually is what happens on the execution side. States have told us that that moves over to the licensure unit and that they have the ability to hold a license if some of the things that they've promised in their applications they've not delivered on. So that could be another thing to think about. And then finally, abeyance. And in most states, they refer to this as layaway. So I'll give you an example of how one state does this, and then you can just think about how different it is in Mississippi. So we talked to one state, and let's suppose this could be nursing home beds, this could be any kind of hospital beds. So in this state, if you want to put a bed into abeyance or layaway, you can only have that bed in there for 5 years. And it goes in and the state sets at year 1 a market value for that bed. If you want to then sell that bed, so leasing doesn't seem to be common, and it sounds like in Mississippi you all have a leasing process. Leasing isn't as common, but there is a buying process that we've heard from other states. So if you want to sell that bed, you're selling that to your competitor or your peer, but you're doing it at the market value that's been set. It's not like you're able to overinflate the cost. Every year that those beds are in abeyance, that market value that the state has set, it decreases until it gets to 0 at the point of 5 years. So you have 5 years of opportunity to either sell the bed or let it sit there because you don't want to sell it to your peer or your competitor. But at the end of the 5 years, the bed is gone from the system. In some of those states, for example, the state has come in. Oh, and the last point is the bed type can't shift. So if that bed was a med-surg bed and you put it into layaway, it stays a med-surg bed forever. Someone can't buy that bed and shift it over to an ICU bed. So just pointing out that the system that you all have is quite different. And just thinking about some options there. On the 5-year time limit, one of the things that we saw when we talked to that state is the state has the ability to come in and do a bed buyback. So let's say that your state says we're overbedded in hospital beds. There are going to be a lot of beds in this region. Nobody's going to sell them. And so instead of just letting them sit there for 5 years and go fallow, the state will come in, they'll buy them and take them out of the system. Again, every year you're losing value in the price of those beds. Stop there and take questions or thoughts on some of these state comparisons.
John, are you going to ask a question about the rural areas or you want me to?
Yeah, I'll ask. So, you know, as we consider the underserved areas in Mississippi, I'm interested in your thoughts as a group about which of two competing forces as related to CON sort of carries the day. So one school of thought might be that CON is effective in helping improve access in underserved areas because they protect facilities that are already established, even sort of protect even a monopoly status, but in doing so, preserve their economic viability so that they can continue to provide those services in a community, versus another school of thought being that CON impedes new practitioners and facilities that might otherwise consider moving into a community from doing so, and therefore they harm access to care in these underserved areas. So you could make an argument theoretically for either effect from CON laws, but I wonder what your experience is looking at other states and what the literature suggests and what the data suggests about which of those two results from having CON wins the day. Does that question make sense?
Yes, it does.
Okay.
So I just want to preface and give a couple examples that we heard, and then I'll get to maybe answering your question. So one of the things that we heard quite clearly was this inequity between hospitals having to go through certificate of need process to do outpatient services versus physician groups that did not. And so one of the examples that someone gave to us is if you're in a rural area and you're the only hospital there providing services, what's to say that a physician group couldn't come in and just open a lab, an MRI, and a clinic? And they're going to come in and they're going to take the business from that rural hospital who already has barely any beds filled, right? So one of the things that we've seen in other states is that hospital can convert on its own with help or without from the state. And so, for example, in Illinois, we talked to our colleagues. The state did a big investment on conversion of hospitals from critical access to observations or rural health clinics or FQHCs. So one of those things is the question of, are we really protecting the revenue stream of the incumbent, or are we keeping them from maybe shifting to a different business model, which the whole region might need? Second thing that we heard is CON isn't just the only place by which you can think about the supply in those areas. So in other states, they use less of a regulatory approach and more of a subsidization approach, right? So you have added rates in Medicaid if you're a community hospital. Your critical access hospitals are on cost reports instead of the way PPS hospitals. So for example, is it up to the state then to subsidize instead of using a regulatory approach to make sure you get the supply right? So getting back to your question about which do you think it is, I've just, we'll triangulate all of this data and information. But my gut tells me, and again, you all may disagree, but, I don't think the part about, what was the second? You said the first option was whether or not it's restricting supply, and the second was, what did you say?
Well, so a second potential effect of CON, having no CON, would be that would actually encourage new providers in an area, because CON is a barrier to new providers, whether it's a facility or
that's what we heard more of. I'm just going to be honest. That's what we heard more of, is that if you got rid of the fees and the regulatory piece on the disadvantaged parts of the state, that you would get maybe. Now, it still costs money, right? And so the question is, if I'm a hospital and I'm thinking about going to an area where there's already a hospital, I still have to think about, whether or not I can cover the revenue, right? And so maybe the approach isn't do it as a hospital, maybe the approach is do it as a clinic. So we did hear that latter explanation that you gave, that you should exempt the disadvantaged areas. I can tell you though, having, in the state where I'm at, certainly that makes the incumbents nervous and we understand why, right? But is that going to incentivize your incumbents to then shift to a different model? And maybe you give them the first option to do that.
So Tennessee, I was struck by Tennessee's approach because, to John's point, the approach A, approach B,
Mhm.
Tennessee seemed to have the approach B. You're not gonna have CON if you're in a economically distressed area. When did they do that, and is there any sort of data on how that's worked?
We'll have to go back to them and look that up. That's a good question. There was some area, and you'll have to forgive me, there's some area where they had some kind of EPA accident or, issue that came up in a part of Tennessee, and essentially people just left in droves for those counties, and so they had to come up with something. But we can ask that question, follow up to Tennessee.
I think that's a good question, Jim. It would surprise me if these underserved and rural areas that income levels are very low, somebody's going to go in and put a huge investment in those areas, given the reimbursement that's out there.
We did hear that from several people as well. They said, what are the odds that someone's going to come in and put, $50 million, $100 million in a place that's disadvantaged. And again, that's why I think some states are moving to a more subsidized model instead of regulatory model. But we will follow up with Tennessee. And also, if you want any follow-up on some of those conversion ideas, we can do that as well.
I'm curious if there's places like Tennessee or Illinois that have taken that approach, that have combined the subsidization with the less regulation. Says, okay, if you're in a going back to, I think it was Anissa's charts of the health poverty levels versus facility, and I was having trouble following the linkage to CON approvals, because it would seem to be more in terms of facilities and infrastructure and utilization, as opposed to people who have tried to apply. But I was curious if you kind of take that approach with the Tennessee no CON if you're economically disadvantaged, and then we also subsidize it because we will pay you more to be there. Are there states that have tried that approach in whole?
Yeah, so we can go back and look, but I can tell you where I'm at in North Dakota, we did both. So we don't, and I'll give you the example, was around behavioral health facilities, residential treatment. We could not get people to build facilities on the western side of the state. We just could not. We got rid of almost all, we don't have certificate of need here, but we don't have a moratorium on those beds. We could not get anybody to build anything. So we did a combination about a streamlined process in terms of getting the facilities licensed and approved, and we did a subsidization. And that was a PPP process, a public-private partnership, where the state put up money, Sanford Health put up money, and 2 facilities got built in that part of the state. There just was nobody who was willing to do it. I mean, even if we did like small community grants of $150,000, they just said no way. So the state ended up putting up several millions to get there. So I guess the question is, and Jim, if I'm misunderstanding, tell me, but the question is it going to take more than just one lever to get people interested into serving that population or adding more services and facilities? And we can follow up on that.
Well, I think that's the question generally. I think my gut and bias is that yes, it's going to take more than one lever. I think what I'm really kind of asking is exactly what you just answered about North Dakota. Are there places that have used the multi-lever approach? Because I've, on one hand, going to John's question, it's like if the state's going to subsidize a rural disadvantaged community provider by providing funds to it, there's one school of thought that says, okay, well, we're going to protect the economic vitality of that where the state is subsidizing it, so that there's not a need for greater state subsidy by people. Something I think you make, Caprice, of people cherry picking more profitable lines of business. So that's one approach. The other approach would be, well, let's take all the shackles, all the regulatory shackles off. Maybe that means that what you see there is going to look different in 2 years, but it's actually more geared towards what's needed. And we're also, to anybody in that service area, we're going to pay them more. Maybe that comes in the form of Medicaid reimbursement. Maybe that comes in the form of state capitalization grants, whatever it might be. I mean, this is two totally different approaches. And I'm curious, because you've said that about North Dakota, and I saw that about Tennessee on the screen. It's interesting to me to see if there's places that have taken the latter approach of, and what the results have been of taking off regulation and increasing subsidization, because it's not where my head would have, I didn't, that's interesting to me.
I mean, and it's, you know, if thinking back, and we don't have to go back through the slides, but where's the action right now? Like your action is not because people are building nursing homes and they're building I know you're the moratorium, but they're not building buildings, you know, PRTFs, hospitals, you know, it's not that. The action is in these places where you're shifting from inpatient to outpatient. That's where the action is. And it's being driven by this disagreement about, you know, how hospitals are treated versus how physicians are treated. And it's on the equipment side. And so, you know, if you did want to take a look at, you know, how many levers can we pull to decrease regulations or subsidize, I would suggest focus, again, like Tennessee said, focus on those services that you're never going to get caught up. Pediatric services, maternal and child health, behavioral health, you know, could you use those as a starting place to look at decreased regulation and maybe some increased subsidization and see if you can get there. The other things that we heard of, a lot more in-home and community-based services that states are pulling the lever on as well, right? So we see in Louisiana where they have Medicaid paying for well child visits where folks are going in the home and doing that, concierge services. We have, you know, you've got this shift for, you know, transferring people out of the inpatient setting back to home and community-based. We're seeing that in behavioral health. We're seeing that in hospitals and nursing homes. And the question is, you know, are there policy levers there, especially in Medicaid, that you can pull to help push that and facilitate that? And I think for all states, the answer is yes. The question is just, you know, is that something you all are interested in? But, you know, the issue of the bricks and mortar is not where the action is in your certificate of need program. At least that's not what the numbers show.
Well, it seems like that's where that's where our debate is right now. It's like, you know, we need to save the rural hospital or wherever hospital model, because we have all these hospitals and they need to be saved. And I know it's very an emotional thing. We need to have hospitals, of course, but you said that we have 40% occupancy in our hospitals right now.
I think it was, more than half of the hospitals have 40% or less occupancy.
So, you know, our focus, in my opinion, should be about, okay, what are we doing to provide healthcare services to the people we need them, as opposed to, you know, the bricks and mortar side of it. And I'm curious, Caprice, what y'all's timeline is for, you know, these things that you've talked about. Do you have specific recommendations that we should take as a board, or we should recommend to the legislature, or what's the timeline for that type of discussion?
Right. So I'm going to defer that to Dr. Edney, because that is one thing that we talked about yesterday. Dr. Edney, do you want to address that one?
Well, in terms of the timeline in general, we need to remember there's the side project of updating and making the data more relevant. That project is ongoing separately. The timeline, we were looking at getting chapter 1 with hospitals done first and try to have as much as we could for this legislative session, and then move on with the other chapters after that.
Caprice, I was just going to point out, I think the issue with bed occupancy in hospitals is not, it should not, at least at this point, be calculated based off of total number of beds in the hospital, but out of the ability of the hospitals to staff only a limited number of beds. And because that's the big determinant now that has created a lot of the crisis that we're dealing with all over the country.
Right, and we saw that in almost every state on the licensure side, they collect that staffed bed. You all
Yeah.
don't. And I know that's one thing Melissa and her team have thought a lot about, and it's been, it's tough on them. One of the things we saw in Alabama that, so each year, so you do your certificate of need application, then you move over to licensure, and then each year they do a quick update they have a form for each of these facility types, hospitals, nursing homes, ICFs, et cetera. There's a quick update that they do each year, and that's all online and transparent. And so an option there is you don't have to redo that entire state health plan report. Is there an ability to take those quick and dirty forms that they have for the facility types, ask them to update their information, and it's compiled and it's put on the website? Now, I know that that's a question about, you still have to clean it, you still have to collect it. But staffed beds is definitely part of what they're showing. And those forms are pretty simple. We're happy to share those with the team and with you all. But that could be an option because we know that how old the data was came up very often. But every time you want to update that data, there's a cost. So is there a way to do that in a quicker and easier? And even the lawyers told us things like, well, we have to do a subpoena, we have to get all the information. And if not, we have to go ask the competitor. So, I mean, there is a data approach that's a bit simpler in some of the other states. We're happy to share.
Do we have the capabilities to measure staff beds versus licensed beds? I mean, Rick makes a great point. I mean, do we have that data, Dr. Edney, or is this intuitive research saying, do we have the ability to get there? I mean, that's an important data point. And then, measuring how far off what we actually need of staff beds versus where we are in reality.
Yeah, that's the critical question, and we get it, but it's secondhand and it's slow. It's not real time. And that's what the central bed management system would be extremely helpful, especially in the wintertime or in times of crises. And right now, systems don't talk to each other, and we're having to pull it from the hospitals every day directly. But there's a lot of work going into that space to modernize that and have better interconnectivity and have more real-time data, but we're not there today.
And I'll just mention, we did talk to Michigan about this issue. They have 4 different ways in which they pull number of beds. I mean, and that seems like if I were a provider, I would not be happy about that. They do have a central bed registry. They do have these interim forms that licensure has them fill out. And they have a way to have interoperability because they have to report this on the Medicare side every night. So they have a way to have interoperability with their major health systems where they can just grab that Medicare report. And it makes it easier on the providers. I think 4 different mechanisms is a bit much, but at least there are options about what they think works and what they don't think works.
It's a complicated issue.
It is.
When you're
Yeah.
speaking of staffing in these hospitals, in the rural markets, you have to include providers there. I'm involved with a couple small hospitals, and if you don't have the providers, you're not going to get the patients in the hospital.
And I think it's not just staffed beds, some of the facilities, is it in nursing homes? Is it your staff? Is it contract staff? Is it staff that you're sharing with the hospital? I mean, it gets pretty complicated pretty quickly, but we got some pretty clear instructions during COVID about how to capture that. And I know Melissa Parker and her team have experience doing that during the COVID time when we had to submit all that to the Fed. So there's some infrastructure there to build off of, but you're right, Mr. Hubbard. It's pretty complicated.
Back to the timeline, what is the next step that we're going to take?
So we are happy we'll meet after this meeting with Dr. Edney and Chris Adcock, and we'll take direction from you, Chair, as well. We have to finish the town halls which hoping to schedule those in December and January. I have all of the surveys. There were 295 surveys that were completed. I have to analyze those, but pretty much everything is pulled together. And the question is, we just need some feedback from you all about what you want. Do you want an executive summary in the next 2 weeks? Do you want a condensed version of, I mean, the original slide deck was like 179 slides. I don't think, we're going there. So we need some feedback from you all as what does the product look like and what is the timeline? And then in terms of the urgency and the speed in which we do it, like I said, we've only got those 2 things hanging out there that we need to complete. And the question is that germane is that really important to what you're doing, or can the town halls be added later? Can the public opinion survey be given to you as a supplement? So we'll take direction from you all. Know that we are available. We've made ourselves available in terms of time. I just don't understand because our contract goes until July. So clearly you want things way before then. So we just need direction from you all of what that looks like, and how quickly you want it.
And
My
just
personal opinion is an executive summary, would give you some educational material because it's clear there's a lot of misconceptions out there, but would also give you some key findings.
And it just, as a reminder, it's very clear that CON is a significant issue for this session. So I think it's going to look very different in April than it does today, in whatever sense that the legislature decides. So, doing a deep dive much further until we see what comes out the other side, may be premature, but the executives.
Well, Dr. Edney, I think I would go the exact opposite direction. I mean, we should be trying to provide good information and good data to inform the legislature and leadership as to what direction we believe from a state health plan perspective would do the most good. I mean, I'm less interested in them operating in a vacuum based upon, we've paid money for a consultant who's gone off and gathered all this good information. We should do something that presents to them thoughts and ideas that could improve the work product as opposed to reacting to whatever comes out in April.
Well, I guess you misunderstood me because there's already a significant amount of work that's been done that's going to be wrapped up. And I think that's going to provide a lot of information to our decision makers. A lot of the particulars are going to change in ways that we can't foresee, but certainly how the state health plan looks, how CON, the information regarding CON in other states and how we're doing things, and everything that you've heard today and even more detailed executive summary, I think it's going to be extremely helpful for the Board of Health and legislative leadership.
So I must have misunderstood because what I was wondering is at what point are we trying to have that executive summary and this information so that it is in fact formally presented to the board and can be given to others. And what I was hearing you say was waiting and see what happens coming out of April.
No, not at all. It's that the executive summary needs to be done before the session starts as soon as we can. I know they need to wrap up the analysis of the surveys and do the town halls, but we need to provide the executive summary to our leadership as soon as we can.
So what we're thinking, we could have an executive summary in 2 weeks, perhaps? Caprice?
Yeah, we will definitely give you that. We might have a placeholder for those town halls. And you can decide when you distribute that, if you take that off or not. I don't think it's going to change the results. I'll just say that. And I don't mean to be disrespectful to the people that are answering it. And so we'll give you the executive summary. We'll get any feedback or revisions. We always want our licensure and CON your licensure and CON staff to take a look at it and make sure we didn't make any inaccuracies. And also, I think, Mr. Hubbard brought up about checking some of the OBGYN and pediatrician numbers. We want to do that for you. So yes, 2 weeks, if that's what you're telling us, we can do. And then also appreciate Chris Adcock and her foresight to keep this contract until July, because if things come up, we're always happy to respond. So if Dr. Edney, calls us and says, hey, there was a question about XYZ, you guys need to go track this down. please let us know.
And just to a point, this made the point extremely well of why a new vision for the state health plan is so important, that I can tell you right now, no one in Mississippi knows how many OBGYNs are delivering babies, or how many licensed certified nurse practitioners are delivering babies, or how many lay midwives are delivering babies. Because no one captures that data. You actually have to go physically count it. And a good example is this publicly made data is inaccurate, by a long shot. So, next step will be, talking to the licensing agencies to ask if they will capture the data for us. At the time of renewal, we can start answering these specific questions that are critically important for the state health plan.
And to that point, Dr. Edney, will, in the executive summary, will there be recommendations of how to improve that data collection to the point of what the examples you were just talking about, and things like the staff beds versus licensed beds versus, need, that those points?
Yes, sir. I think that would be important to do. And then anything else the Board of Health were to think of.
We certainly heard unreliable data and outdated formulas frequently, haven't we? Caprice, could come also, can the board will meet January 10th. Could you plan on, we could even Zoom you into the board if you couldn't come in person, but
Sure.
I would think the board would like to have another discussion with y'all about where we stand with this evaluation.
Yes, absolutely. We'll plan on that. And just to put a point on what Jim said about the staffed bed versus the licensed bed, happy to do that. We might categorize the recommendations or the key points that we heard, some of which that are germane to chapter 1, some of which were 2 to 7, some of which were outside of those, but were about basic data infrastructure. So we'll try to categorize this so you're not just sitting there looking at a list of 40 things. So.
And we are certainly interested in your expertise and your recommendations for the direction the board should go with this.
Sure.
Any other comments from the board? Are we okay with a strategic plan? Is 2 weeks right, or do y'all need 3 weeks? I mean, I would think if we could just get it before our next board meeting and enough time for us to review it.
I mean, I would really like to have it before the session starts.
So you said strategic plan, you gave me a heart attack. You really meant executive summary.
Executive summary.
Okay.
Forgive me.
Yeah. I mean, I think it's in our best interest to get something done by the holiday, then give it to Dr. Edney's team to, make sure it's accurate. And then I think we're fine. It's all there. It's just putting it in the format and putting enough context to it. So yeah, I feel pretty comfortable with that. Chris will.
So the legislative session starts the 2nd of January. So if we could
Okay,
get it by then, that would be good.
sure.
I think
Chris
we should-
Wilkes, am I speaking out of turn? Are you okay with that?
No, that sounds good.
Okay. That will be our goal.
And executive summary is what I meant.
Yes. Okay.
Board members, I know we need to call this meeting and adjourn this meeting, but are there any other comments for our guests or for our general discussion? If there is not, do I hear a motion to adjourn?
So move.
There's a motion and a second. All right, we are adjourned. The deed is done. Have a good day, everybody.
Thank
you so
y'all.
much.
You all too. Merry
Bye-bye.
Christmas.